Hi, my name is Courage. I'm second year medical student. I've been asked to come examine the nerves in your face. Is that okay? Right, so in the course of this examination, alright, I'll be looking at your face, I'll be touching your face, alright? And I will also be asking you to perform certain movements. If this causes you any discomfort, please let me know and I'll stop. Alright? Okay, so before I start, I'd like to say, have you noticed any change in your sense of taste lately? Sorry, have you noticed any change in your sense of smell lately? Right, so patient have noticed no change in the sense of smell, which means cranial nerve 1 appears to be intact, which is the olfactory nerve. Alright, so moving on now to cranial nerve 3, 4, and 6. Right, I'm just going to perform certain movement I just want you to follow. Right, so just keep your head still, alright, and just follow my finger, alright? So moving here, and here, and here, back, side, here, here. I'm going to bring this close to your eyes now. Alright. Convergence, accommodation. Alright, and then just follow this down as it goes down. Alright, so I just checked right now, I just did the H movement of the eyes to check for ocular movement. I also did convergence, alright, and I also did for lead lag. Patient had no lead lag, alright. Convergence test was fine, alright, and in terms of the H movement, extraocular movement rate was 4 and 3. I couldn't appreciate any nystagmus, right? So that's 3, 4, and 6 done, which is oculomotor nerve, trochlear nerve, and the adducent nerve. So now I'm going to move on to check for cranial nerve 2. So in order to check for cranial nerve 2, first I just want to do a quick diplopia screen. So give me your eyes open. How many fingers can you see? 1. So close your right eye for me. Still how many? 1. Okay, then left eye for me. How many? 1. Alright, so the patient has no double vision right now. But again, I would like to also do the Snell's test. Alright, normally I would like to use the Snell's chart. Alright, I'm looking to use the Snell's chart. I will ask the patient to read, starting from resetting letters and see what the visual acuity is. Alright, and ideally I would expect a visual acuity to be 20/20. In terms of visual acuity, the numerator, the distance at the numerator represents the patient's sight, and the distance at the denominator represents the normal sight. So a visual acuity, for example, of 20/40 means that the patient can see the letter at a distance of 20, alright? And meanwhile, the observer, can see that same letter at a distance of 40. So a visual acuity of 20/20 is a good visual acuity because the distance are equivalent, from which we can both see the letter. Alright? So we are assuming the visual acuity is normal in this case. I would like to proceed now and do the pupillary light reflex. We'll pretend that this is the pen touch, and I'm going to be shining this in the patient's eye. So we'll pretend that I'm going to be shining this in the patient's eye. Alright? So I'm going to sit up and tell the patient, I'm going to be shining this light in your eyes. It might cause you a slight discomfort, but it won't cause you any pain. Is that okay? So normally when I shine the light in the patient's eye, alright, I will expect the pupil to constrict. Bearing in mind that the pupillary diameter is 3 to 4 millimeters, right? But I will expect the pupils to constrict upon shining the light in the eye. And when I take the light out, the pupil should return to normal size. Alright, so you just shine the light in the eye, and right, direct reflex, alright? Then the other eye, right? This. Alright, so the pupillary light reflex is normal, alright? Okay, then moving on, I want to also now do the visual acuity. The visual field. So for the visual field, alright, I will want to sit down. Before trying to do the visual field, I want to quickly check for circadian reading. So I'll put the fist out, alright? I'll put the fist out and put my palm out. And I will ask the patient to please keep your head still. Just look at my hands, my fist on my palm. So palm, fist, palm, fist. Alright, good circadian reading. Alright, good voluntary pursuits as well. Alright, I do not send any nystagmus to this one. Alright, so now moving on now to the visual field. I would just like you to please close your left eye, please. Left eye. And I'll close my eyes. And just tell me when you can see my fingers wiggling. Alright? You see it? Alright, so starting from the lower temporal visual field to the lower nasal. You can see it? Alright, starting with superior temporal to superior nasal. Alright, and I'm just going to close this eye as well. You can see it. Alright, good. So we're going to repeat that. Alright, you're closing your right eye now. And I'll close my left eye. So let me know if you can see that. Okay. And again.
Yes.
Okay, I'll put this on the way. Keep that close.
Yes.
Yes. And again.
Yes.
Okay, thank you. So the patient has no loss of temporal vision, alright, and also no loss of nasal vision. If she had loss of the temporal vision bilaterally and intact nasal vision, then the patient probably had what we call a tunnel vision, alright. So that appears to be fine in this case. The visual field examination was normal, there was no visual field defect. Ideally, I would like to now proceed to do an ophthalmoscopy or a fundoscopic exam using the ophthalmoscope. In a fundoscopic exam or ophthalmoscopy exam, I would want to first of all check for the red reflex in both eyes, starting from the side, alright?